Okay, so we're going to go back to our panel, and I'm going to ask Marge to respond because I think Erin's comments really speak to the value of community efforts for youth and the Virginia Foundation for Healthy Youth. Marge and I have worked together on the Tobacco Free Alliance and a number of initiatives in Virginia, and you all know that we're a tobacco state, so it is an uphill battle on a good day. So the work that Marge and the foundation do are incredibly important, and so I'd like her to speak to some of the projects and some of the kinds of things that are priorities for your foundation.
Well, again, we focus on tobacco, obesity, and substance use prevention. And we focus on youth under the age of 18. So our role is really about primary prevention. And we heard about modifiable risk factors, and generally in public health, most organizations focus on mass communication campaigns, and we take a very different approach. We have something that we call peer crowd science, and it is starting to roll out nationally with some publications on this issue. And what we do is we kind of look at how typical companies advertise their products. Things are sold to us every day. And we use our peer crowd science model in identifying peer crowds of youth who are at most risk for some of the modifiable behaviors related to obesity, tobacco, and substance use. And what we do is that we try to market behaviors to those groups so that they can bring them in as part of their peer culture. And it's really based on typical advertising science. We have targeted campaigns toward 3 primary peer crowds right now: alternative, country, and hip-hop. All 3 of these groups are double or triple the risk of using tobacco products, not eating healthy, and not exercising. So we're really focusing on those groups of kids, knowing that there will be spillover to other groups of kids as well. What we're trying to do is replace unhealthy behavioral norms with desirable healthy lifestyles within those peer crowd targeted interventions. And our approach really is to promote the positive aspects of things, such as a new campaign that we're going to roll out that really focuses on the benefits of simply drinking water versus drinking sodas and power drinks and those types of things, because we know something simple like that among youth and really among their families can make a big difference in their lifestyle choices.
Great. Thanks, Marge. Kim, can you talk for a second about, from your perspective, what are the kind of challenges and what are the things that prevent people from thinking about these lifestyle changes that we've been talking about, and how it, what are your perspectives on it?
Right. So as you've heard, modifying these risk factors is important and can prevent cancer. The big problem is people don't do them. So you can talk about weight loss, you can talk about quitting smoking, and those are very helpful, but if you can't get people to actually implement them and continue those behaviors, it's problematic. So this is where social support psychology and the science of psychology can come into play, with working with people both as groups and individually to really help them get at some of the root of this. Some of it is access, obviously, and we've got to work at this from multiple angles. To provide access, some of it is education. Many people still in this day and age don't know this. We had someone here who didn't know that obesity was associated with breast cancer, or at least there's literature to support that. So education, providing more access, and then finally providing the support and the help to make the changes that will be effective in reducing cancer risks. And to do that, we have in the field of psychology and social work a lot of models that are very effective at helping to motivate people, to get them more ready to change. There's something called motivational interviewing and motivational enhancement therapies that we routinely use at the Cancer Center to help people get ready to change or clarify some of their ambivalence about it. in a way that they can receive, where they don't push back. That's the other risk you have with people when you tell them to quit smoking. You can't tell me what to do. We call that the writing reflex. So it takes some finesse to work with people to clarify their ambivalence, help them set goals that are realistic, and then move in that direction. And then more of the behavioral therapy can come into play to set these goals and a pace to help people quit smoking who are already doing that, or prevent more addictions from accumulating. What you may not know or think about that often, but I think about it a lot as a psychologist, is that for many of these folks with high risk because of their lifestyle choices, there's a lot of comorbidity psychologically. So you have a lot of depression, addiction, anxiety that go along with it. And often, to really find a lasting change that sticks, you've got to address those underlying issues. And that's where we also come into play. This is why there's often social workers, psychologists involved in treatment at the cancer center level or out in the public when we're working with public health issues. So those are the things that we do day in and day out, both in our prevention arms and also helping people once they've been diagnosed, getting through treatment. And you have to remember the people that are in survivorship. They're still needing support as well. Often they're very much at risk for some recurrence, and so they need to continue these healthy lifestyles and have the support.
So I think that's really important. So all of these decisions about lifestyle and changes in your life and how you're living your life are very emotional, and they have emotional levers attached to them that are not always really obvious. Exactly. The funniest story or the most interesting story I have is that a friend of mine who was a smoking cessation counselor talked to a woman for 15 years about quitting smoking, and it wasn't until her dogs got diagnosed with emphysema that she realized that there were consequences to that behavior. And they were her family because she was single, and that was her family. So it is a very hard thing for people to do it for themselves. They need to have, that's why the support systems and the support of healthcare professionals is incredibly important. Kim talked about motivational interviewing. Do you guys know what motivational interviewing is? It's where you actually become their advocate and you help them make decisions as opposed to telling them what to do. Are you interested in quitting smoking? Would you be willing to set a date? How can we help you? It's a much more positive, I'm on your team kind of perspective, which also helps things. So I think, those kinds of things are really important. I'm going to ask Vic, can you talk a little bit about, because even doing vaccines is a very emotional decision, and your expertise in HPV has historically had some really interesting perspectives around it. So if you could talk a little bit about HPV and how it relates to women's health and those kinds of things, that would be great.
Sure. Thank you. And, I think this is one of the few cancers which is somewhat unique in the aspects of the fact that we know what causes it, and we have very effective tools, both for primary but also secondary prevention. I think the obvious nature of vaccination preventing disease is somewhat common in infectious diseases, but this is one of the few chronic diseases or cancers which are preventable by vaccination. And I think this is one of the few interventions for the past 10 years that we have had, which has not been optimally utilized. The uptake rates of the HPV vaccine in the United States continue to be around 70% for girls and around 50% for boys, although it's recommended widely for the past 10 years or so for girls and about 8 years for boys. This is a challenge because this is something which can be given at an early age, can be combined with other childhood vaccinations around the age of 11 or 12, but has been somewhat suboptimally advocated by physicians and pediatricians. So a lot of the efforts are currently focused on empowering and basically improving the communication that exists at the provider and patient level to improve access to vaccines and sort of combat the misinformation campaigns that go around vaccination so that it becomes part of routine care. It gets promoted as a cancer prevention in intervention rather than an intervention against a sexually transmitted infection alone, which is what usually has all the challenges around patient communication and stigma and embarrassment issues. But there's also a connection, not just to the vaccine, but also to screening. I think what's somewhat lost in what we know about HPV-related cancers is the fact that cervical cancer, which is almost 100% caused by HPV, continues to occur in about 12,000 cases in the United States every year. This, in spite of the fact that for the past 6 decades, we have had a very effective screening strategy, pap smears. 4,000 women continue to die due to cervical cancer every year in the US. And I think every case of cervical cancer is one of the greatest public health failures of our times. I would probably put it in one of the things where we can do something, not just in the prevention domain, but also in the screening and early detection domain. About half of all cases of cervical cancer are in women who have never been screened or have been suboptimally screened. And I think part of this is related to healthcare disparities. They still occur in parts of the country and counties across the US where healthcare access is a problem. And there are several interventions that are currently undergoing to improve that access. It's in rural Appalachia, it's in the Deep South, it's in American Indian reservations. I mean, there are several, and in some inner cities as well, where access to cervical cancer screening still remains suboptimal. I think from both the primary and the secondary prevention point of view, this is one of the cases where we can make a lot in terms of intervening and optimizing the current interventions.
No, that's really helpful. So in terms of a community perspective, so I'm going to ask Nancy, I'm going to ask you because you're in the primary care area, what, aside from what you do in your office, what other kinds of things in the community do you think as a primary care physician, with your local hospital, I mean, what kinds of things do you think we can do to try to help educate better? Or are there other resources in the community that we should pull in? What do you think?
Well, obviously having access is a large issue, but we were speaking about this earlier, and one of the problems, particularly as people get further away from their education or from educational institutions, so when you work more rurally, I'm working in an area where we do have medical students come up, but we don't have a medical center. I mean, we've got a medical center, but it's not a large teaching institution. I see that primary care providers tend to stray away from the recommendations that they have learned that is evidence-based. And, whether it's nutritional or vaccine-related, a lot of people who are primary care providers will end up getting their information from other sources that may not be evidence-based. And so some of the recommendations tend to change. There's a lot of mixed messages that are given to patients. And unfortunately, if you don't trust that the research that's being done and the evidence-based medicine is the best knowledge that we have today that is in the patient's best interest and safety, then we're kind of doomed to have a lot of failures. And this goes for HPV vaccinations, certainly disease prevention, and even nutritional information. When providers are coming across and giving people information on nutrition that may or may not be really very good or evidence-based, we have difficulties in terms of moving our communities forward in a uniform kind of way.
All right. No, I think you're right. I think access is a major point. Erin, can you talk a little bit about are there support systems in the rural environment that could be tapped that maybe are being underutilized, like churches or local schools? Do you have any ideas about?
Well, yeah, the local stakeholders, community partners, we try to work together to do some things. So we at the UVA Cancer Center, we have something called Cancer Center Without Walls. In Southwest Virginia, we work with the local community partners like churches and the schools. But still, the healthcare, the access to healthcare, that's the big problem. Because we know like the disparities in rural Appalachia is mostly caused by lung cancer. And then when we look at the lung cancer screening facilities, there's just not many there. Like in Virginia, there's only 2 or 3 and shared by like 40 counties. And they have to travel hours to get the lung cancer screening. Plus, there's not, after lung cancer screening, they don't have smoking cessation service available to the smokers. So what's the point of doing the lung cancer screening without offering them, smoking cessation services? And they only have like 800 quit line for them to call. They don't have local smoking cessation programs. We're trying to do something there to offer the service. But there's another issue is Kim talked about the mental issues in this kind of risk prevention, risk reduction. There's also biology reasons behind like smoking and the addiction. Nicotine is the addictive content in cigarettes, and the nicotine actually helps people to boost the metabolism and suppress your appetite and improve your mood, control stress. That's a lot of reasons people can't cut it. So it's about 85 to 90% of people are not ready to quit. And now we're designing a study to replace their normal nicotine, the cigarettes, with the low nicotine cigarettes, so to decrease their nicotine dependence. And one day they will say, I'm ready to quit, and then we can do something about it.
Marge, can you talk a little bit about sort of your relationship with not only the youth? I know you've had a number of a very active smoking cessation program for youth, but can you also talk about how that maybe relates to sort of whole families and parents, and are the youth actually able to impact the broader community in terms of smoking cessation?
Oh, yes. We really take an approach in two ways at the community level. One is to engage a lot of sectors of the community outside of healthcare, because people in the health realm have interest in cancer prevention. But we also try to engage kind of non-traditional groups in the work that we do with our healthy community action teams. And then secondly, we have a very robust youth engagement program that we term Y Street. And in that way, we engage youth throughout our state to be part of this movement. And we train the youth, and we probably have 1,000 active youth in our state right now. They take on campaigns, and some are focused on policy, such as our 24/7 tobacco-free school grounds campaigns. And it's really up to the youth to become advocates in their own communities by talking to their school boards and convincing them to take on policy change, which then affects the broader community when the community comes together for school-based events, such as athletic events, and having policies where no one can use tobacco products anywhere on the school grounds or at school events. And in this way, we believe that our youth are not only being prepared to become advocates throughout their life, but they're actually having an immediate impact in their community. And let me tell you, just from experience, taking youth up to our legislature and having them talk to school boards is very effective. Legislators love having the kids come talk to them. They love the photo ops. So I would encourage everyone in this room to find a young person in your community when you're going to do your advocacy, train them and take them along, because they're very effective.
Okay, great. Well, good. Let's talk a little bit more about, Nancy, can you talk a little bit about prostate cancer and active surveillance and what you're seeing in the primary care audience? Because we've talked a lot about women and we've talked about smoking cessation, but I think prostate cancer continues to be another one of those areas that there's been some mixed messages about the testing and what is the best approach for treatment.
Yeah, testing remains ever-changing, I think, with prostate cancer. We have the PSA test and we have the digital rectal exam, and I tend to be in the camp of testing both. We have two tools in the toolbox as a primary care physician, and for a while we were going away from PSAs, and there's still some evidence that PSAs may not be the most effective way of screening. Certainly digital rectal exams. I think one of the things I'm unfortunately hearing quite a bit from patients is that they continue to not get digital rectal exams as recommended by their primary care providers. So we need to be encouraging our physicians and primary care providers to be doing proper examination. Obviously, that's the first step. Interesting, I ended up reading through a study, and it basically said in the U.S. prostate cancer is the most common type of non-cutaneous cancer in men. Many men are diagnosed with limited volume, low-grade disease, where a watch and wait approach is appropriate, which is considered active surveillance. Results of the prostate cancer lifestyle trial, it was a 2-year. It was at 2 years. Patients who had adopted intensive lifestyle changes it was actually a vegan diet, moderate exercise, and stress management with group support showed that men in the experimental group had undergone significantly fewer conventional prostate cancer treatments, which are things such as radical prostatectomy, radiotherapy, and hormonal therapy, compared to the control group. Additionally, the experimental group had significant improvement in cholesterol levels as an added benefit because they made such large lifestyle changes. The results of the study concluded that the men who participated in an intensive lifestyle program were able to delay conventional treatment without any detriment to their health and with associated benefits of overall reduction in terms of other lifestyle things, cholesterol levels, but also an overall decrease in expense. So when we look at our active surveillance for prostate cancer, certainly being aggressive and doing procedures can have detrimental effects in that people will have problems with erectile dysfunction and urinary incontinence. It may not be fully necessary depending on the patient, and active surveillance means that that patient is being watched very closely by somebody so that if the disease does progress, then a more aggressive stance can be taken. But when you look at the economics of prostate cancer, it was extremely interesting. This was from 2008. They cited that the first 6 months of treatment for people who have radical prostatectomy, the costs in 2008 dollars were approximately $12,000. For people undergoing radiotherapy, radiation therapy, it was about $24,000. Hormonal therapy was about $8,700, and active surveillance was $2,600. So if you look at the system, and if we're spending money and doing things that make sense for the patient, certainly being able to provide very good care for patients with no compromise, but also being able to proceed forward where we're using our dollars wisely makes a lot of sense.
Right, so that is another access-related issue and requires a very coordinated, I would guess, interprofessional kind of approach to that care. I'm going to ask Vic to talk for a second. You're one of my science guys, so talk a little bit about clinical trials and where you see things are going. I know your primary area is HPV, but it is an area that is still underutilized. And what other kind of clinical trials? I mean, what kinds of things from a science perspective do you think are going to be really important for us in the next couple of years?
Sure. So this is one of the areas, as I said, we know a lot about the virus which causes the cancer, but this is one of the areas where we can define as one of the precision prevention approaches. We have a precise means to prevent it, but we have not yet optimized it. What we are hoping to do in the primary prevention domain is, because we have such we have such enormous challenges in uptake and such low uptake rates, we are trying to investigate actively in a very large randomized trial whether fewer than the recommended 2 doses of the HPV vaccine are as effective, which means essentially is 1 dose of the HPV vaccine as effective as 2 doses. This is an outstanding research question which is really has a emerging evidence base to it, but unless we have a large randomized trial to effectively answer that question in a head-to-head comparison between 1 and 2 doses, that answer would not be solved. But if it is solved in the next several years, we might be able to get to a point where we can do much more with less, and it will be a much less of an inconvenience for the whole system and for the patients. We also hope that with emerging HPV screening technologies, not just relying on pap smears, but replacing it with a much more precise method of screening, which is now approved as a primary screening tool for women 30 years or older, would be a transformative method to reduce the over-treatment or over-screening, if you will, particularly replacing annual screenings, which has been the norm in pap smears, which much less frequent screening, therefore, and yet not lose any of the detection at the same time. That balance is ideally achieved with some of these newer screening approaches like HPV testing in the same manner that pap smears are collected. So those are the areas where we see a lot of the efforts going towards, both in the secondary prevention domain and reducing the number of vaccine doses in the primary prevention domain. We're also looking at improved methods to treat women who have pre-existing HPV infection and pre-cancer. At this point, the current methods are excising part of the cervix or ablating the lesion of the cervix, but those can lead to obstetric complications or infertility. So we are trying to look at methods which could involve all the way from a therapeutic vaccine, as we call it, an immunotherapeutic approach, to a woman-oriented, woman-delivered, self-applied topical agent, which could effectively clear the virus or reduce or induce regression of that lesion. So we go through a spectrum of those research areas where our goal will be to improve on current methods of treatment of cervical precancer.
Oh, great. Thank you so much. Kim, I'm going to ask you to sort of be my final presenter this morning, and then I'll open it for one or two questions. But can you talk a little bit about what the value of what kind of supports people need sort of throughout the continuum, both from not only screening, but then dealing with cancer diagnosis and then ultimately survivorship, and why an interprofessional sort of broad-based approach would be helpful?
Absolutely. So I alluded to this before, that I think we have to focus on the whole spectrum of prevention, helping people once they've been diagnosed and through treatment and then after treatment in survivorship. And I think it does take a team. I also think it's important for us in this day and age to think about the fact that it needs to evolve as well. And so I think the ongoing support, not just in education and access, is important, but also helping people really get to explore, why are they avoidant? What is keeping them back from either engaging in prevention activities or engaging completely in treatment? And a lot of that can be done by an interdisciplinary team, especially one that involves someone from social and behavioral sciences to help clarify ambivalence and provide support. I think, though, we will need to think outside the box going forward about what that looks like. And I would challenge especially the young, innovative people in the room to think about that, because, I was at a meeting the other day and I heard that I don't know if it's happened yet or if it's going to happen, but you can go to CVS or they're planning this or something, and if you think you have a UTI, get diagnosed, get your treatment for $19 at CVS. That sounds like heaven to me. This is where we're going towards, and so where are we going to reach people? How are we going to reach them for prevention? It's not going to be the old ways we've done. It's going to need to be innovative, creative ways, things that we're all thinking about here, but beyond that. That's where we need new minds and energy to think about what will prevention look like. I helped with a gentleman named Judd Brewer from Yale develop an iPhone app called Craving to Quit, which is what we designed especially because not everyone can access tobacco cessation. We've hired more tobacco cessation folks at UVA, but we need to find lots of different ways to reach people, to help them know how to not develop these bad habits and also to quit them if they have, and then to get them through the treatment. We have a lot of folks coming for cancer treatment at UVA, and they're coming from 3 and 4 hours away. They can't come for a support group every week. So we need to think about how are we going to meet their needs? How are we going to get them through? Because we know having that support, either one-on-one or as a group, not only helps you get through the treatment, but there's evidence from a wonderful woman named Barbara Anderson at The Ohio State University that an organized program of support through cognitive behavioral therapy actually helps you live longer after treatment. And so we need to be able to provide that and think of new, innovative ways to do that because it does make a difference.
Great. Nancy?
I just had one thing to add to that. When you look at a lot of these studies, part of the success in studies in terms of lifestyle and behavioral modification is a key component is group support. People are going through it together. You have 20 people in a room, and they actually can bond to each other. And a lot of times, if you can see a lot of these programs, there's a community health initiative program. They're 18 weeks worth of 1-hour programs a week. You get these people and they actually can discuss their successes, their failures, their difficulties. They become friends and they support each other through that. You see a much higher success rate, a much higher rate of adherence over time. The big key with this is we have to get insurance coverage for it. I would love to do group visits and bring everybody in, but we really need the insurance companies to be on board and realizing that these are important preventative group meetings that should be supported.
Yeah, Marge, I'm going to ask you to comment one more time because I know your group, because you're dealing with youth up to 18, you guys are using social media quite a bit and some other strategies that those of us who are technology immigrants are not quite as familiar with or comfortable with. They tried to teach me how to tweet and gave up and said, never mind, just don't bother. So, I know that lots of people do, but I don't. So can you just talk a little bit about because you guys have been doing a lot of work with social media.
Yes. Well, certainly we do post things on Facebook for our adult audience because we know that youth are not there typically. So, so with youth, we do use our Y Street youth to participate in social media. We recently had a challenge via social media regarding our what we're looking at in obesity prevention, and we try to encourage youth over 13, according to law, to engage in a challenge with us by posting pictures of things going on around their school that exhibit healthy lifestyles, and then we gave the school system an award for whoever had greatest participation. So we're engaging youth that way. We do use all of the youth social media platforms to push out messages that are relevant to them. They're not adult language oriented, they're brief, and we do use Snapchat, Twitter, a variety of mediums for that because we really want to look at where youth are at, and the messages, as I said, are very different than what we might put on Facebook for adults.
Okay, great. So access is really ubiquitous, right? So it's not just being in a particular place or in a particular community, but virtually as well. So I think I want to thank the entire panel for their time and effort this morning. Really good discussion. Thank you so much.